link to the YouTube if you guys want to look at it. So we're going to talk about kind of three things: dry AMD, and then I'll switch to another lecture, it'll be wet AMD, and then the next lecture will be other causes of CNV that aren't AMD. So we'll just kind of play this by ear. So here's our outline. I've actually made this outline a few months ago and I haven't looked at it since, so we'll see if it actually ends up being that way. Okay, so AMD, leading cause of central vision loss in people over the age of 50. We talked about yesterday diabetic retinopathy 20 to 64. So really with retina in the US, you're dealing with the major causes of blindness for most folks. Less than 20 is something else, but glaucoma, trachoma is not really an issue here. Glaucoma is an issue, but not the number one. And then cataract's reversible, so it's lots of fun surgery, but it's not that. There's not a whole lot academically to talk about it. I'm sure somebody would disagree with that. Lots of people have dry AMD. Not as many people have wet, right? 15 million versus less than 2 million. And we have 200,000 new cases of wet AMD every year, and that's probably going up because of the baby boomer generation. They're all kind of hitting their stride. Normal aging, photoreceptors are reduced in density and distribution. You have melanin granules that are going down in the RPE, and you get these lipofuscin granule formations in something called residual bodies. Basal laminar linear deposits accumulate, and choriocapillaris undergoes progressive involutional changes. We know that from a long time ago, but we also know that from the recent EDI OCT data that Rick Spade produced in New York, who looked at enhanced depth imaging OCT, where we can, and swept source OCT is even better. You can actually get it all in focus at once, and so at any rate, we know that with age, your choroid's going to get thinner, and the more myopic you get, your choroid gets thinner. So if you're already really like a pathologic myope, and then you get old, your choroid's less than paper thin. So risk factors for AMD. I just typed this slide out yesterday. Family history. Some people actually want to call this genetically related macular degeneration or gene-related macular degeneration because genes are actually more associated with it than age is. Obviously, you have to achieve a certain age, 50, but in terms of a risk factor, the genes predict more than your age does once you hit 50. Cigarette smoking, hyperopia, okay, not something I thought about as a resident, but myopes don't develop AMD as much as hyperopes do, right? Light iris color, looking at you blue-eyed guys over there. Tamana and me, we're good for hopefully protected a little bit longer, although I have two grandparents that had AMD, so I'm not excited about that. I'm excited about them, but not about the AMD in my blood. All right, hypertension, hypercholesterolemia, female sex, and cardiovascular disease. So, because this is kind of a dry lecture, pun intended, let's see, who doesn't have food in their mouth? Dr. Benyon. Mm-hmm. And next time we'll get somebody food in their mouth. Can you describe this photo for me?
So it's a color fundus photo of the right eye showing kind of diffuse macular, soft, yellowish spots. The optic nerve looks also, you can see some scleral crescent nasally. Don't see any edema or abnormal blood vessels.
Great. So if I gave you three categories of drusen, small, intermediate, and large, where would you place these guys? My goodness, turn that thing off. 201. Don't answer any phone calls.
Oh, is that Wilford Hall?
Hey, Wilford Hall. Did you ring? No, and... All right, well, anyway, let's keep on going. Okay.
I'd go with small or medium, probably small.
Okay, so does anybody know what the criteria are for intermediate? That's the easiest one, because if they're outside that range, they're either large or small. Let's see. Vincent's doing something important. Dr. Moses. Intermediate, what are your criteria? Or what are the criteria? Your criteria important too.
Anything like between 60...
That's right, yeah. Yeah, exactly. So 64, 125. And how do we know what 125 microns is? How, like...
It's about the size of a retinal vein at the disc margin.
Excellent. All right. I always got vein and artery mixed up as a resident and fellow, but you're right, it's vein. And not everybody's the same. And some discs are anyway, whatever. So if we say when a vein crosses the disc margin, it's 125 microns. That's the upper limit for intermediate. So half of that is 64. That's how, or 63, 62.5. So that's kind of how we decided intermediate. Not that we all sit around going, do you have intermediate? But it is actually somewhat important. And if it was your eye, you might be interested to know. So looking at that, would you say that these are in the intermediate category, small or large, John? Some of them are in a slightly different category, but the vast majority kind of fall into one category.
Most of them fall into small. I don't know, there's some.
Well, you're right. It could be. I was thinking more along the lines of the larger ones fit into the intermediate. So, but you're right. There are a lot that are tiny. So if you look just nasal to the fovea, there's a few little tiny guys, but then a lot of the ones superior to the fovea, for the most part, fit into that intermediate side. Again, we're splitting hairs, and I would never spend this much time shining bright light in a patient's eye just to figure this out. You look at, it's intermediate, right? Okay, so then you can characterize them as soft or confluent or discrete. And these are, for the most part, discrete / hard. So let's keep on going. Food in your mouth, Jason Croskrey. How would you describe this photo?
I see some large exudates with some of them appearing confluent. So this photo of the left eye.
Oh,
and,
okay, go ahead.
that was said at the beginning. Just pretend. And so I see some larger exudates that are, some of them might be confluent, coming together, mostly superiotemporal to the fovea.
All right, so let's talk about the word exudate. So exudate means what?
Something, an exudative process.
Right, like something got extruded and it's left over. And maybe on a sort of ontogynous sort of level, maybe these are extruded in that way. But these are, we don't typically categorize drusen in an exudate category. So in the old days, there's this term soft exudate, which I like to throw around just because it's kind of fun. It's like wearing one of those old hats from the 1920s that kind of look like they're made out of cardboard, you know. But exudate, soft exudate's a cotton wool spot / an NFL infarct, which some people disagree with. Hard exudate is really what we mean when we talk about exudates these days, and that's usually related to an exudative process where fluid shows up, swells up the retina, and then it's like a high water mark, and then it gets reabsorbed, but then some of the lipid component doesn't get reabsorbed as well, and that's left over. So we talk about that in diabetes or BRVO, things that cause macular, and you could certainly get with AMD, specifically wet AMD, hard exudates. In this case, I would characterize these as drusen. And you're right, I agree, they're large, and some of them are a little confluent. They're kind of starting to share their sides with each other. So, and maybe a hyperopic disc, certainly not a myopic looking disc. Okay, so genetics. Yawn. All right, CFH gene. Okay, so these are the ones that the book lists. It's actually way more complex now, and there's actually much better data now, but I was a zombie yesterday, and also I don't want to overwhelm you, and I'm not going to test you over this very much. Basically, there are 3 genes that they list, and then they list a couple others down at the bottom. The CFH gene, the HTRA1, which I think used to be called ARMS2, but don't quote me on that. And then this LOC387715 gene. So those second 2 that are listed, they actually tell you how much more likely you are to have AMD if you have them 5-fold and 7-fold. Okay. Genetics is becoming this has played a bigger and bigger role. I'll say this, it's actually somewhat controversial now. Controversial for eye doctors. So there's a guy, I don't want to name any names, that has a company that basically has looked at the data retrospectively from AREDS multiple different ways and looked at their genetics and basically found that certain genetic profiles not only do not benefit from micronutrient supplements, you know, we talk about AREDS formula vitamins, but they might actually get worse. But he also owns this company that makes the genetic tests so you can find out. So there's a big conflict of interest. And by the way, when it comes to conflict of interest, that's a big deal. When somebody says, I have this, 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 and this, that really means don't listen to me, don't listen to me, don't listen to me. Don't just say, oh yeah, he disclosed everything. He didn't disclose how much money he got just for coming to talk to you. He didn't disclose how much money he's getting every year. We're talking tens of thousands of dollars, if not more, plus that fame and recognition. And this could probably, who cares if I get in trouble? What could anybody do? The military certainly doesn't care about this because they agree they don't want me in the pocket of somebody else. So I really want you to think about that when you go to meetings, because the people that speak there oftentimes are in the pocket of a company, and some of the people that aren't. So like there are really great people out there that still have said no to big money and big pharma, big industry, and sometimes anyway, this is a longer topic, but I do want you to think about this critically, because just because somebody says their disclosures doesn't mean, okay, they did their due diligence and now we can listen to whatever they say. You really can't. So it's just something to think about. Even having just stock interests, that could be a conflict of interest, but we're talking about much more than that. So this person might actually have something, this guy whose name I'm not going to say, because it's just not polite. He might actually have something valid to point out, but he's got such a big conflict of interest, it's really hard to hear what he's saying. And the person who's his sort of antagonist or protagonist maybe works at NEI, NIH, and she's made some really good arguments as to why he's sort of manipulated the data. But maybe, in fact, if we actually redo the data prospectively, he ends up being right. Certainly it's compelling to me, but not to the point where I'm testing all my patients at this point. But it is kind of scary. We tell everybody, well, not everybody, I'm about to get to that, but we tell a lot of our AMD patients, you should take these medications, they're very benign. But then I say medications, supplements, vitamins, and then we find out later on they're not. Vitamin A is a great example. But then what if it turns out, genetically speaking, we really should profile these people? I think he has a really good point, but his conflict of interest is terrible. Okay, so differential diagnosis, I think I just kind of was trying to think of stuff this isn't in the book, but CSR with diffuse RPE changes, I meant to throw in a picture. Pattern dystrophy, which is a little bit of a wastebasket term, but it is a real entity, and people do get idiopathic CNV from them, and they don't behave the same way as wet AMD. Malatia leventinese / Doyne honeycomb dystrophy / dominant drusen / who knows what name's going to come out next, can look like dry AMD as well, and they probably have similar risk profiles. And then drug toxicities can look like this, although I really don't think so. With OCT now, we can really kind of half most of the differentials that are in the retina book, because once you get OCT, you go, oh yeah, it's not a macular hole, it's actually plaque mineral toxicity. Things like that maybe prior to OCT were harder to differentiate. Okay, AREDS simplified grading scale. This seems somewhat testable to me. It's not something I go over with every patient, partly because there's still a lot of uncertainty, but basically you come up with this point system, right? If you have one or more large drusen, you get a point. Each eye gets, a point for that. Presence of pigment abnormalities gives you a point. If no large drusen, but you have bilateral intermediate, that gives you 1 point. And then if you have neovascular AMD in one eye, it's 2 points. So we're obviously caring about the other eye. So then we use that and we can stratify their risk, right? Add up the number of risk factors they have, and then we say 5-year risk, 10-year risk. In general, the 5-year risk starting with 2 risk factors doubles each time, 12, 25, 50. And so the 10-year risk came out after as a resident, so I never really memorized it. But at any rate, if you wanted to stratify somebody, you could. And that's their 5-year risk of developing advanced AMD, which, as I recall, is either neovascular AMD or central involving geographic atrophy. Okay, so here's how you manage it. If they have vision loss present, please get them to low vision. Even if they're just 20/40, they're having trouble reading. Low vision can do wonders for them. We have low vision, I think, here, but we also have it at Wilford Hall now. A lot of folks don't like to go downtown that are in the military, so send them here or there. People that are 2200 or worse, sometimes with low vision, can read again, and that's a big life changer. And they have these big you guys actually have a low vision rotation, right? So you've been to it more recently than I have, but they have these closed circuit TVs. People can slide their iPads under them, blow up the image of the words on the iPad, and then it blows up even more. And I have a patient whose best vision is 2200 and his better seeing eye, or 2125, 2150, and he's reading way more books than I am. And it's really amazing, but without that technology, you wouldn't be able to. Teach them how to use an Amsler grid properly, right? So 1 eye at a time, reading distance, blah, blah, blah. And then to come back if they see that. And I always qualify it, and I say, listen, even if you got an appointment coming up in 2 weeks, I still want you back within a couple of days. Don't come in the middle of the night. It's not going to be fun for anybody. But come during the next duty day if you can. Lifestyle modifications. obesity reduction, smoking cessation, blood pressure control, I say sunglasses. Regular exercise is not in the book, but a lot of survey data is coming out and saying, listen, if you run greater than a mile a day, and not many people in their 80s are, you have a very low chance, or much lower chance stratification-wise, of developing AMD. And then micronutrients, we'll talk about that, and I already kind of talked about it a little bit. We're doing good on time, I think. AREDS enrolled a lot of people, age-related eye disease study, right? And they looked at vitamin C, vitamin E, beta-carotene, zinc oxide. Anybody know why they add the cupric oxide? It's in the book. To prevent zinc-related anemia, right? So I know there's a reason, a rationale for why they included these supplements. I actually don't know what it is. I meant to read up on it. My impression for beta-carotene is that it's like the old wives' tale, you got to eat carrots and have vitamin A for good vision. That literally might be the reason why it's in there. I don't know. So they found that if you had intermediate AMD, and that's qualified as extensive intermediate drusen, that's why I showed you that picture earlier, or at least one large drusen or non-subfoveal geographic atrophy. If you have subfoveal geographic atrophy, probably not going to benefit a whole lot from supplements. You're not going to prevent, even if you prevented progression, it may not make a big difference for you. Or if you had advanced unilateral AMD, okay? So these are the people that would benefit from supplementation. So they had a 25% reduction of risk for progression to advanced AMD at 5 years, and they had a 19% risk reduction of moderate vision loss. They qualified moderate vision loss. Yesterday we talked about like doubling the visual axis. They called it greater than 3 lines of vision loss, which depending on your vision chart can be the same thing. And then at 10 years, 34% of the supplement recipients had advanced AMD versus 44% of placebo. I know that's a 27% risk reduction. It doesn't seem like that great when you go 34 versus 44. The number needed to treat, I was thinking might be like 10 to get one person that actually benefits from it. But that's a big deal. So anyway, things to think about. My next slide might be blank. Nope, it's not. Okay, good. There were some blank slides this morning when I got in. Okay, AREDS 2 results came out 18 months ago, but the book does not have them. That's fine. But it's important for your patients to know. Now, we've known this before AREDS 2 came out. Beta-carotene, we knew was harmful for smokers. For whatever reason, despite other big studies, people that have been former smokers or current smokers, were getting higher rates of lung cancer. Other studies did not have that same thing. But beta-carotene was super scary. We had the smokers formula and the non-smokers. Now we found out beta-carotene not helpful at all. So even if you've never smoked one cigarette in your whole life, raise your hand. I'm just playing. You guys can but you did. It's fine. I smoked a cigar once. Maybe I shouldn't say that, but it's no big deal. It was not fun. So it was peer pressure. It was when I was a resident too. So anyway, can I get back on the right track? Here we go. So beta-carotene is not helpful for anybody. So even if you haven't smoked, and it doesn't, I don't know about cigar smoking. Maybe it's a little more healthy. I don't know. Okay, no benefit. Number 2, lutein and zeaxanthin are of benefit, right? So I don't know if you've been to the grocery store where they have the AREDS type vitamins. Have you been there? It's like 13 to 14 different formulations, and each major brand, Ocuvite and all those other ones, they have like 3 or 4 different formulas within each one. And so it's really complex. I took a picture, and I meant to print it out, but I would show patients on my phone, you need this one, not that one. But the main thing that I tell them, well, I'll get to this in just a second, lutein, zeaxanthin, no beta-carotene, vitamin C, vitamin E. Now, we know from survey data that eating fish, if you're in the upper quintile versus lower quintile, is protective. But we gave everybody in AREDS 2 omega-3 fatty acid supplements, didn't benefit their AMD. It might have benefited their cardiovascular status, but did not help their AMD. So they don't have to take the fish oil tablet, or maybe the benefit is actually something about the omega-3 fatty acids that are native, that are like, naturally in fish. And there's a company that we did a study with a long time ago as a fellow, and they said that theirs was like the ester, or not the ester. They had the more natural form. Anyway, the study didn't go very far. But the point is that eating fish is still thought to be helpful. Taking fish oil tablets for AMD, not worth your money. Okay, now that's like maybe 5-year data, so maybe 10-year data will be better. And then zinc was reanalyzed. We found that you could take a lower dose instead of the 80 milligrams, take 25, right? Okay, and lamopolizumab is in studies. I haven't heard any recent data, but the soonest it could get FDA approval is about 2 years from now. And it slows the progression of dry AMD based on geographic atrophy measurements in terms of surface area. So, but it's an injection. At any rate, and the other weird thing, we might talk about this in the next lecture, is that some of our anti-VEGFs may actually increase the progression of geographic atrophy. Okay, so that's interesting. Sad. Okay, so this is just an OCT. You might be tempted when you first look at this to think, hey, there might be some intraretinal fluid there. There's some geographic atrophy centrally, as evidenced by the fact that you have increased hyperreflectivity within the choroid, right? And then you see some drusen, little bumps along the RPE, maybe a little epiretinal membrane. This one has more fellow eye, same patient. Okay, and then there's some drusen and some geographic atrophy centrally. So this patient had an FA done. Autofluorescence first. Rick Spade, again, can't say enough about the work he's done, but he showed that there might be like kind of a third form of AMD. We talk about wet, we talk about dry, but he talked about this other form that's progressive, and you get this photoreceptor atrophy over time. So at any rate, we'll talk about that. Well, actually, we won't talk about that right now. So you see some areas of hypoautofluorescence centrally in both eyes, and you see the drusen. You get this kind of almost leopard pattern on the right, on the right eye, but on our left. And then this is the right eye. This is 4 minutes and 12 minutes. And one word, what do you see here in terms of the pattern of hyperfluorescence? Dr. Milstead.
I wanted to say staining.
Yep, that's all you have to say, staining. So there's not, actually some people argue that drusen pool, but that's a different topic for now. It's not leaking, that's the main thing. What's that? Is that what you're saying?
No, I said shouldn't it be getting brighter if it's...
It can be, but
Okay.
we're already way past
Okay.
recirculation. We're in the late recirculation phase, but yeah. And I didn't show you the earlies at all either. I don't know why I didn't show you the earlies. Maybe they were crap. So anyway, left eye, similar patterns, right? Okay. So those are my references. Let's go on to the next lecture.